Hello, this is Adam Rosen. I'm an orthopedic surgeon who specializes in hip and knee replacement. I created this video as a review for my patients to review some of the risks involved with knee replacement. This is informative only and not medical advice. If you are looking into knee replacement, you need to speak to your orthopedic surgeons about specific risks, which may be specific to you and your health conditions. A brief overview, though, will review the majority of the risks that we do worry about. Luckily, because this is a very common operation and has very low risks, we have gotten to the point where it can be very successful. However, with any surgical procedure, there still are a number of risks that we have to worry about. First and foremost is the risk of infection. That is always a concern, and one of the most disastrous things that we see after knee replacement surgery. So to reduce the risk of infection, patients do get antibiotics before and after surgery. We also have you complete a series of washes at home prior to coming to the hospital to decrease the bacterial load that typically lives on your skin. We also do, as part of our preoperative workup, a nasal swab to determine whether or not you are a carrier of staph. Some people are, and if that is the case, you will be treated with a special antibiotic ointment at home to again decrease your risk of infection. Another important thing that we look for to decrease the risks of infection are dental problems. The mouth is a source of infection, so we may have you get dental clearance, and if you have active issues such as a fractured tooth, a broken tooth, a cavity, or severe gum disease, this may all need to be addressed prior to your elective knee replacement surgery. If you're a diabetic, your diabetes needs to be under good control, and if you're a smoker, you need to quit to minimize the risk of infection. The other risk that we worry about are blood clots. Some people are at higher risk than others, so that is something that we have to look at and stratify in each individual patient. One of the simplest ways to prevent the risk of infection is to get up and walk. The more ambulatory you are, the lower your risk of developing a clot. The other thing that you'll find that we use in the hospital are compression stockings. These circulate the blood while you're in bed. And then we may also put you on a medicine, something such as aspirin or another heavier or stronger blood thinner in either pill or injection form that is very specific to you and your health conditions. The other thing that we do worry about is blood loss. Luckily nowadays, the risk of bleeding and needing a blood transfusion is very low. We typically use a medicine during surgery, which has helped minimize the risk of blood loss. We will check your blood count before surgery. Patients that have a low blood count or are anemic, they may need a further workup, sometimes requiring supplements of vitamins or things such as iron to build your blood count back up. Now, as far as therapy after surgery, that is a potential complication as some people will develop stiffness. There are a very small number of patients that will develop severe stiffness. We call that arthrofibrosis. We still don't truly have an understanding as to why that develops or who it will happen to, but luckily it is very rare. One of the biggest things that you can do to prevent stiffness is more aggressive physical therapy and early range of motion. We typically will get you started with physical therapy the day of surgery. If it's a late afternoon surgery, your first session may be the following morning. But the quicker that you get moving, the less risk of stiffness you will have. And even at home, we will have you continue on a scheduled basis of range of motion exercises to obtain both full straightening and full bending. Typically, patients after knee replacement will get anywhere from 115 to 120 degrees of motion. And the biggest indicator of where you will be after surgery is how much motion you have before surgery. Patients that preoperatively have severe stiffness may have a more difficult time obtaining full motion. Patients that have excellent motion before surgery but severe pain from arthritis may get better motion after the operation. The other thing that we do worry about are risks with the wound. Wound complications can occur, but luckily are quite rare. If you are a smoker, again, quitting smoking decreases that risk. Certain medications may inhibit or slow down the wound healing. So again, that's very specific based on each individual patient, and that would be discussed at your preoperative evaluation. Other things such as fracturing of the bone, injury to ligaments, injuries to nerves, arteries, or veins all can happen with any surgery, but they are extremely rare. The other thing that we do worry about as far as the operation is pain, and pain management is something that has changed a lot over the years. The operation itself hasn't changed much as far as the technical aspects, but we have done a better job of making the procedure more tolerable after surgery. The way that I do that with my patients is that preoperatively, all of my patients will get a cocktail of pills that will be given in the pre-op area prior to you going to sleep. This way, when you wake up, that medicine is in full effect. The other thing that we do is with the anesthesia team, we have them place a nerve block. That nerve block blocks a large majority of the pain fibers in your knee, both during surgery and after surgery for 24 hours. So this allows people to get started with physical therapy right away with less pain. The next thing I do is after the operation, before closure of the skin, I inject the knee with an additional amount of numbing medicine. Again, that helps decrease the pain that you will feel and experience after the surgery. Now, for the next few days and weeks after surgery, people will experience pain. Our goal is to manage the pain so that you can sleep, walk, do physical therapy, and if that's the case, your pain is controlled. It is impossible to make someone's pain a 0 on that pain scale in the weeks following surgery, but we try to manage it effectively that you're able to participate in physical therapy. To do that, I haven't designed this, it's not my idea, but it's become pretty standard and typical around the world, the idea of what we call multimodal, non-narcotic, scheduled medications. And what that means is trying to use medications that are given around the clock, not just as needed. And we also try to use non-narcotic medications first, because the narcotic medications are the medications that carry the highest risks as far as constipation, itching, rash. Some people can start to feel very fuzzy or groggy, and it may lead to tolerance, potentially addiction if it's used long term. So what we do around the clock, unless there's a medical reason not to, what we typically use for most patients is acetaminophen, which is Tylenol. That would be given around the clock, and you'll continue that for a minimum of 2 weeks at home. The other thing that we use is an anti-inflammatory, which is given again around the clock, both in the hospital and at home for a minimum of 2 weeks. We also use in the hospital a nerve pill, which will help desensitize the nerve. That's used for 24 hours after surgery. Simple things such as ice will also help control the pain. An aggressive early range of motion does help. What I find is patients that get more motion quick, they get more motion early, they all tend to have less pain and they tend to have a shorter recovery time. The other option that we use for pain control are the narcotics, and those are used more for a breakthrough drug. So you will get a prescription in the pre-op appointment so you can have that filled and waiting for you at home, but you will use that only as your breakthrough drug. Most people will use that the first few nights at home or in the first week or so after physical therapy. But by week 1, 2, and 3, most patients are on a routine schedule of the Tylenol with an anti-inflammatory. Now that covers the majority of risks. Hopefully that helps answer a lot of the questions that you may have regarding what are some of the risks of the surgery. The anesthesiologist on the day of the operation would talk to you in more detail about the specific risks involved with the actual anesthesia. Now at your pre-op appointment, you may have different medical conditions, which will dictate a deeper discussion on specific risks, which may be specific to you and your health